of the survey instrument. This survey draft also went through a series of revision. We engaged with experts from menstrual health hygiene as well as measurement who provided us feedback on our first draft. We also received feedback from IRB boards in Nepal and Kenya. A lot of valuable feedback came from our data collection partners. And a very important step was the cognitive interviews that we undertook with our team of enumerators. Though our preliminary plan was to engage with, with the general population, unfortunately, due to COVID and other related challenges, we had to engage with our team of enumerators, and we did a round of cognitive interviews with them. What the cognitive interviews allowed us to do was test the content and face validity of our instrument. Uh, it informed us on what items were not being properly understood, so that allowed us to revise those items, or it allowed us to eliminate questions that we felt or we got feedback from through the process that were culturally inappropriate or contextually inappropriate. It also helped us to test the translation of the instrument as well. And the final survey draft, again, during the training as well as the piloting, also went through another round of revisions. So throughout the process, we were keeping in mind that the final instrument that we will then test has to be as robust as possible. Moving on, with respect to the instrument, we field tested it. We field tested it in 2 urban settings. One was in Nairobi, Kenya, and Kathmandu Valley, Nepal. These are also sites where IRIS has their ongoing workplace interventions in menstruation. And our target population, or the respondent for the study, were adult women over the age of 18, employed outside of their home for payment in either cash or kind, who has experienced menstruation in their workplace. In Kenya, the recall period was 3 months, while in Nepal, we had extended it to 6 because they had extended lockdown due to COVID situation. So to ensure that, we had respondent groups who could provide insights, we increased the time span. The respondents also went through COVID symptom screening just to ensure the safety of our team. And of course, they formally consented to participate in the study. Our sampling approach was also twofold. We started with a purposeful selection of districts and sub-counties in Nepal and Kenya. This was through discussions with IRIS team as well as our data collection partners. And within each of the neighborhood that we selected, we randomly selected households by just knocking on every 3rd house to see whether there were eligible women who were available and willing to participate in the study. So the insights that we will be presenting, or Bethany will be presenting, comes from around 1,064 surveys, 632 of which came from Nairobi and 400 from Nepal. As I had already mentioned, that we did a random household sample. So most of the interviews or the surveys were conducted at their home, with some exception in Nepal, where women requested us to conduct it in their workplace, though they were recruited at home, assuring, while our enumerator team took care to ensure that there were privacy and they were able to concentrate on the discussions as they provided us inputs. Bethany, over to you.
Thank you so much, Anu.
Just 1 second. I'm just going to mute myself so that you don't.
Sure. And then it stopped presenting mode. There we go. Great. So first, I'm going to talk about the revised conceptual model. So at the crux of this model is work menstruation experience. This was something that we talked to IRIS Group and USAID folks early on about, that regardless, I mean, we know from other WASH research that you can have access to WASH facilities, whether sanitation and water, but your experience might not reflect whether your access. So it's really important to understand work menstruation experience, including practices and needs, self-efficacy, and bodily integrity. And also determinants that might influence work menstruation experience. So we looked at determinants at multiple levels. First, the workplace level, including social environment, institutional policies, as well as the physical environment, which is inclusive of wash and resource availability like materials in the workplace. At the individual level, we looked at access to resources and include materials, pain management, social support, and also knowledge as resources. We looked at demographic factors as listed on the screen, and also looked at the biological level, including pain and symptoms and reported heavy bleeding and irregularity. We also looked at outcomes, including individual well-being and individual employment. Well-being outcomes included health, comfort, safety, stigma, and social impacts. And individual employment factors included absenteeism and presenteeism, ability to complete work, earnings, and job satisfaction. Ultimately, we think that these all lead to potentially longer-term impacts, including economic empowerment, future revenue streams, and business and workforce impacts. Now, the reason why this conceptual model is important, you may not have been able to see on the approach slide that Anu shared, but there are some important characteristics when thinking about choosing indicators. And UNICEF has laid these out in their MHH monitoring guide. But one of those is to think about monitoring along a theory of change. Theory of change is most appropriate for programs, as most of you know, looking at programs or interventions. But similarly, a conceptual model can serve a similar purpose. So we adopted this conceptual model in order to think about how and what we are tracking along each of these stages in order to measure and assess along these. So when we present the results, we'll be presenting along this conceptual model. So before we delve into the specifics, we have a poll here. And so what we want you to do is fill it out. And the reason is because we want you to think about, and for you and for us, think about where you come from as you're seeing these results. So are you somebody who's brand new to this topic? Do you have no knowledge, some knowledge, or a lot of knowledge about menstruation? And also, based on that knowledge, if you have any, and it could be none, based on your assumptions, in which country do you think menstruation-related experiences might be better for women while working? And the reason I'm having you do this is because I want you to sort of think about your assumptions before we get into the data, so that when you're looking at the data, consider how that might influence questions that you might have for the end. And it also helps you situate your own positionality. So please fill that out when you have a moment and look at how others are responding.
So for those who can't find it, it's under the triangle, square, circle thing in the bottom right. Got 5 votes. I know there's more than 5 of you on.
Thank you, Lisa. Okay, I'll have you move on, Anu, and then we can look at those at the end. So before we get into the specifics of the data along that conceptual model, I think it's really important that we talk about who we engaged. Now, because of COVID, we assume, but potentially other factors, it was actually quite hard engaging participants for this work in both countries. A little bit harder in Kenya. Of the households that we approached, only 37% of those approached actually resulted in a full completed survey, where that was around 47% in Nepal. The majority of those that didn't participate was either because they refused sort of outright, or the houses were inaccessible, or had a gated community, or somebody was just simply not home. So this is important to note, because we were trying to find people who were working for the most part during working hours. We did the best that we could to also engage participants during weekends or evening hours, but that is one thing to keep in mind. Next slide, please. Also important to know is we share a few characteristics of the population. The mean ages are comparable here. As you can see, there's the majority of participants in Kenya are Christian, and while the majority in Nepal are Hindu. But really what we want to point out here that participants in both countries were very well educated. Only 5% in Kenya and 14% in Nepal had primary education or lower. So the majority had secondary or higher, which is really important to think about. This could be simply because of the research question we were asking about people who were engaged in work. Next slide, please. Also important is their work background. Other studies, there has been one other preprint that's been recently released by Dr. Hennigan, and she proposively sampled women working in Uganda at markets, schools, or healthcare facilities. So as you can see from this, because we had a random sample, which is also really important for testing indicators, seeing if they're applicable across different subsets of participants, we have a larger representation of work types. Interesting, though, also about this population is that the largest proportion in both countries engage in professional or office work. And what I've done here is also highlighted with these red boxes the sort of other highly represented work types here as well. There are both professional or more formal and informal work types represented in our population overall. And finally, a little bit more background, just simply related to COVID. So as you can see from this bar chart, the majority of participants in both locations actually experienced no change at all related to COVID in the previous 6 months. So again, that might reflect some of the findings that we're seeing is that their impacts and their employment was not necessarily affected by COVID. That being said, the majority of participants in Kenya, not the majority, a larger proportion of participants in Kenya did have impacts on employment compared to participants in Nepal, including losing their job, needing to change their job, or being temporarily laid off. We also asked a few questions specifically about menstruation related to COVID to further provide context. What you can see here is that a greater proportion of women in Kenya than in Nepal reported purchasing difficulties, while overall the majority did not have any challenges. Next slide, please. We also found that a greater proportion, nearly half of the participants in Nepal reported that they had difficulty accessing their preferred materials. So the previous slide showed us that more women in Kenya than in Nepal had challenges related to purchasing, but specifically when it gets down to accessing their preferred materials, 50% of the participants in Nepal indicated that that was a challenge. And a greater proportion of participants in Kenya reported difficulties changing their menstrual materials while working. So this bar chart shows various reasons that women would have reported having difficulties changing at work. And again, while the proportions aren't particularly high, and the greatest proportion, over half in each country, with close to 90% in Nepal reported no challenges, we see that there were some challenges simply accessing the place that women typically changed at work, that challenges related to longer wait times, and also that around a third of women in our Kenya population just simply felt uncomfortable in the place that they used to change their menstrual materials because of concern related to COVID. Okay, so now we're going to get into the key findings along this conceptual model. And so one of the things that I want to just remind everybody, as Lisa pointed out at the very beginning, is that ultimately what we wanted to do is arrive at a short set. So I am not going to be presenting all of our data with you all today, but I'm going to really highlight specific data and related indicators along this conceptual model. The report is being finalized and it will be available. Our survey in total had around 200 different items, and we're presenting really only around 10% of that now. So please stay tuned for that. And just, if you have any other questions, please feel free to ask. The chances are we have the data and we can answer any questions about that we're not specifically reporting on here. So first, we're going to talk about determinants at the biological level. So this slide shows pain and symptoms reported by the respondents. Participants could report more than one type of symptom that they experienced, and what you'll see is that the half of the participants in Kenya and 65% in Nepal had reported 2 or more symptoms. Interestingly, participants in Nepal, a greater proportion of participants in Nepal than Kenya reported each type of symptom. The other thing that I wanted to note here is that we didn't just ask, do you have pain? How intense is your pain? Though we did ask about that in separate questions. We asked an array of questions about identifying the types of pain that people experience or symptoms that people had. And the reason that we did this is often because typically programs, if they pay attention to pain, it's less paid attention to compared to other facets related to menstruation. It's typically around physical pain, but as you'll notice from this bar chart, we also ask about irritability, anxiety, and tension, fatigue, weakness, and dizziness, also loss of or changes in appetites. These are important to note because the experience of menstruation and pain is, and symptoms, is myriad, and not all of it can easily be solved through simply providing pain medications. We also found that a greater proportion in Kenya self-reported having irregular periods, and also that a comparable portion reported experiencing heavy bleeding. So if you can advance just a little bit, what's really important about these biological level measures is actually that they don't make good indicators. So the other thing that's really important to consider related to indicators is that we're measuring something that's changeable over time. We're not likely to see any changes in whether or not people experience the types and a variety of pain that people experience, unless of course they have remedies or ways of treatment, or their irregularity or heavy bleeding. However, this is still really important information to capture because it tells us a lot about our population. Next, we're going to talk about individual level determinants of menstruation experience. Interestingly, we found related to material access that a larger proportion of women in Nepal than in Kenya reported always having enough menstrual materials to change them as often as they wanted to while working outside the home during their last menstruation. So in terms of an indicator, our proposed indicator here is the proportion of women reporting always having enough materials to change as often as they wanted. This specific indicator was largely informed by work and another indicator proposed by the Global MHH Monitoring Group's priority list of indicators for girls. So this work is being carried out in tandem right now. This list is currently being revised and will be in press and also translated in multiple languages. It specifically focuses on girls. The other thing, this is an important point to note, that when we were identifying and selecting our indicators, one of the important things that we wanted to do is have alignment with other ongoing initiatives. So that group, which includes a core group as well as a wider group that includes country stakeholders with a lot of revision based on external input, felt that for a material indicator, having enough was particularly important compared to simply just asking about preference. So preference was important, but ultimately having enough was the priority. Next slide, please. In terms of knowledge and pain management, we found a greater proportion in Kenya reported that they could not usually predict the start of their menstruation, and that a greater proportion in Nepal reported that they were always able to get the pain remedies they needed during their last menstruation. So while we talked about those biological determinants, these very much relate to those. So at an individual level, indicators are more appropriate. We felt that the proportion of women reporting that they can usually predict when their menstruation will start was a proxy for knowledge. While this can be influenced by women's irregularity, one of the things that has been identified by other groups is having some sort of indicator related to knowledge of the cycle and how the cycle works. And so this is the one that we landed on. The other indicator related to pain is adapted from work from UNICEF. Next slide, please. Now we're going to talk about the workplace level. First, we looked at the social environment. So among women who reported working with other women, we asked them about their experience in the workplace and what women in their workplace, whether or not they hid that they were menstruating or not. And this is actually quite a strong difference. A much greater proportion of women in Kenya reported that other women hid that they were menstruating. So one of our proposed indicators to get a sense of the social environment informed by some work and UNICEF was the proportion of women who reported that women in their workplace hide that they are menstruating. And next, this subheading shouldn't actually say social environment, it should say workplace policies or rules. So one of the things that we wanted to do is try to get a sense of what women were allowed and not allowed to do. So what we did is we investigated whether or not they were allowed to take a break. And so a greater proportion in Kenya reported that they could take a break to meet their menstrual needs whenever they needed to. This indicator is also adapted from work put out by UNICEF related to girls in school. Next, we're going to talk about physical access to a physical environment related to material access. What we found is that a greater proportion of women in Kenya reported that their workplaces provided materials, whether free or at cost. And I thought this was actually quite interesting because those of you who work with people in Kenya or from Kenya know that there's actually great effort in Kenya to provide resources to girls in schools. So to see this sort of be consistent and also in the workplace is quite interesting. So the proposed indicator here, again, adapted for the global MHH monitoring group, is the proportion of women whose workplaces provided menstrual materials to employees, whether free or at cost. The idea here was just simply about access, not necessarily whether they had to pay for it. Next slide. So now we're going to talk about the physical environment. And before I get into these data, many of you might be aware that, assessing the physical environment, water and sanitation access in schools, typically that is done by asking schools to self-report what facilities they have. Also, what the JMP does, the Joint Monitoring Program led by WHO and UNICEF in regard to school monitoring, is that they also have a subset of teams that will go and be a third party to sort of to assess school facilities. Assessing workplace facilities is not necessarily something that I think is going to be taken up by any government. Also, there's going to be quite a bit of variability in the type of workplaces assessed and also potentially the standards by country. So as a result, in terms of assessing the physical environment, the best that we can do is ask individuals about their workplace environment and sort of self-report. So these indicators in this section are adapted from the JMP, but are adapted to be asked at the individual level for ease of monitoring. So we have a proposed basic indicator here, which is the proportion of women reporting that they have access to sanitation facilities that are single sex at their workplace. So what you'll see in this data is that Kenya and Nepal, around 77% in both countries, reported that there was access to a sanitation facility at their workplace. But a much smaller proportion in Nepal, which is not necessarily reflected here by the size of the circle, have access to a workplace facility that is for women's use only. Next slide, please. So now we have a few that are a little bit more advanced, and they're more advanced because they require a little bit more information than just simple sex segregation, sort of hearkening back to that idea of having a short list for governments to take up. Answering these questions requires a few more actual measures, a few more questions to answer the actual indicator. So this is why it's a little bit more in this sort of advanced stream. So the first one is the proportion of women who changed their menstrual materials at their workplace, specifically at their workplace, in a space that was clean, private, and safe during their last menstrual period. So you'll see a greater proportion of Nepal had access to these places at their workplace. Next. The next indicator is similar, but it's not at the workplace, it's while working. So, one of the important distinctions we made early on is that we didn't want to just ask people about their workplace. We wanted to know what their experiences were. And this is important because not all people have a workplace. As you'll see, we had some people in our sample that worked as in a domestic capacity where they moved workplaces, moved from place to place, moved from household to household, moved from space to space. The other thing, and we talked about this a little bit early on, is that even if you have access to a facility where you work, it doesn't necessarily mean you're going to use it because it might not suit your needs, or there might be other reasons. So it was really important for us to ask about while working. And you'll actually see that when you look at these numbers, they're actually a little bit better. So when we're asking people while working, this place was clean, private, and safe during their last menstrual period. And next, we have now another indicator that adds a few elements to this. So not only while working did women change their menstrual materials in a space that was clean, private, and safe, we also added whether or not it was lockable, and whether or not it was available when needed. And you'll see that those proportions drop dramatically. And then finally, the proportion of women reporting that there is water and soap available in a private space to manage menstruation, a much larger proportion of women in Nepal reported having access to a space like this. So again, work menstruation experiences, we'll get into these. And again, I just want to highlight that we intentionally asked questions about while working and not at your workplace. In terms of practices, in both countries, a very high proportion of women who needed to change their materials reported actually changing while working during their last menstruation. And this specific indicator was adapted from, again, the global MHH monitoring group list. We also investigated bodily integrity and self-efficacy. So bodily integrity is largely about having control over your body and being able to make preferences that suit your needs. So we looked at the proportion of women who reported that their work responsibilities prevented them from addressing their menstruation-related needs at least some of the time during their last period. And this is actually a pretty high proportion. So, you know, approximately equivalent in both locations, a pretty high proportion were not able to address their needs at least some of the time during their last menstruation at work. Next, in terms of self-efficacy, we proposed two indicators, one about working and one about managing. So the first one is the proportion of women who reported not feeling completely confident working during their last menstruation. This number is really high for Kenya. Almost all the women reported not always feeling completely confident working during their menstruation. And then the proportion of women who reported not feeling completely confident in their ability to manage menstruation outside the home, similarly, really quite high for Kenya. So we see in the previous, when we were looking at workplace access, when we were looking at material access, those, if we looked at those just by themselves, we would think, oh, people are not really doing that badly. But not all of them are completely confident in their ability to manage work or menstruation. Next. Now we're going to look at outcomes. And an important note about outcomes, if you could advance this, Anu. So these proposed indicators related to outcomes may be most suitable for program or policy works that is specifically looking to change these outcomes. These are not necessarily the best for a global or national level monitoring, because they might be really far removed from the determinants or experiences that might be influencing them. And there also might be varied other factors that influence these outcomes. So it's important to keep in mind that they might be best suited for program or policy level work, But it's really important. We think that these are here because they provide a standard and a tested measure for people going forward and doing work in these spaces. Next. So first we looked at menstruation-related stress and tension. During their last menstrual period while working, a greater proportion of women in Nepal reported having never experienced stress or tension when they needed to access a location to change their menstrual materials. And so while that is a pretty good indicator, we also have to look at the negative in that a good 17% and around 30% in both locations did have experienced tension or stress. Related to safety, we found a greater proportion in Nepal never had any safety concerns about changing while working. But again, what the inverse of that indicates that there is some concern about safety among these populations. And next, we also tested some measures related to earnings. We found a slightly larger proportion in Kenya, though still not a large proportion, reported lost earnings or reduced pay in the previous year because of decreased productivity or missed work related to their menstruation experience. And you will see here the proposed indicator on the side. I won't read through all these indicators so that because of time, I want to have some time at the end, but they are aligned with the actual data. So if you can go to the next slide. In terms of job satisfaction, we found that a greater proportion of participants in Nepal agree that they are satisfied with their ability to meet their menstrual needs at their current job. And so this is really interesting related to the bodily integrity noted before, and also in the self-efficacy. So even though there were scores related to self-efficacy, a lot of people did not feel completely confident. They still felt satisfied with their ability to meet their menstrual needs at their current job. And next. So I wanted to get through the end of the data because I think now it's important to sort of reflect a little bit and have a discussion about the data that we presented and the indicators that we proposed. So first, I want to just talk about some of the key strengths of this research and this approach. First, we haven't identified a potential list of indicators. We presented today on 10 of those indicators. There are actually 12. We'll be sharing these slides and you can look through all of them. The other ones we didn't present on largely because they were, the proportions were high numbers. And so they might actually be candidates to not include. Most, for example, high proportions of women had access to pain medications, and that was one of our proposed indicators. Unclear if that should be continued because there's not much variability in that. So we have this identified list of indicators for assessing menstruation, and these can be taken up and further discussed. Most indicators, also a strength is most indicators were adapted from existing or proposed indicators, whether related to the household level, school level, or specifically to girls. And we think that this is really an important facet of this because we want to maintain alignment with those other initiatives, and also because there's been a great amount of vetting and review by broader groups of stakeholders for those indicators. Next. We tested these measures in two very different populations. Kenya and Nepal are very different geographies. They're very different culturally. To be sure that these were widely applicable. Certainly further testing needs to be done, but that provides more confidence in what we're proposing. Also important is that we randomly sampled women to engage. And this produced a diverse sample. So we talked about this a little bit at the beginning in terms of job type. We were able to engage a more diverse sample of job types but we also still have the caveat here that we have to think about the population that we reached and that we didn't reach. But the random sampling, the other thing that I'll add about the random sampling is that if any of these measures were to be adopted by DHS or MIX, again, they are randomly selected populations, so we're confident that these can be adapted into those spaces. Additional outputs of the research are also a strength. We have a revised conceptual model, and not only can this inform future work on menstruation, this might also be something that can be used to think about program design as well. And next, we also have a really robust and tested final survey tool. So this full survey, or even relevant sections of the survey, can be adopted by others to standardize what is measured, whether in research programs, whether in research or programs, in order to enable comparison. So this tool, as well as the report, is going to be made publicly available and hopefully promoted for adoption. We also have the final report. And so as I mentioned in the very beginning, what we really presented on here is a very short list with a little bit of additional information related to participant demographics and also COVID. But the final report has a tremendous amount of information all along that conceptual model and will hopefully be a critical resource for many in the future and also a point of comparison. And next, we have a data set that is immense. We have, like Anu pointed out in the beginning, over 1,000 participants, with 40% of those from Nepal and around 60% from Kenya. And so there's a need to leverage this data set even further and to actually see how along the pathway there might be some associations with how determinants influence experiences and then in turn influence the outcomes that we measured. And then finally, limitations and next steps. As I really took care to point out at the beginning, these data reflect a very specific time. We're not really sure how data would have panned out 2 years ago in pre-COVID. And related, the population we engaged was also very specific and related to this period of time. There might be bias in our sample because people might be out of work and not able to participate. There might be also bias in our sample because, as I noted, we knocked on a lot of doors and people either weren't home or refused. It's really hard for us to know specifically if the sample that we engage is like the sample, is comparable to the sample that did not engage. So there could be some bias. We also did not intentionally target or report on transgender or non-binary individuals, and we also did not include individuals under age 18. There's a need for deliberate research that engage these populations, and one of the reasons that we didn't engage these populations is due to ethical considerations. We also weren't specifically asking people about transgender or non-binary status, and it can be risky for some of these populations. The other thing is that in order to do research with people who identify as transgender or non-binary, or to specifically even engage people under age 18, we might have needed to have a different sampling approach that was not random. And next, the data presented here are just descriptive. So we need to do further analysis to understand who is having the most challenges with menstruation during while they're working. And then finally, the indicators proposed need further vetting. So again, we leveraged and leaned on the work being done by others, but the reason that work is a little bit further on than ours is because they've also engaged in-country stakeholders, experts in menstruation, experts in measurement. We did that to an extent, but not with this short list. And so there's a need for further input and buy-in. Also identifying gaps, what should be added, what should be taken away, to really hone in on a finalized short list. And then the only other thing that I would add here that I didn't add as a bullet is that there's also a lot of opportunity from what we found here to do further qualitative work to try to understand why we saw what we're seeing. And with that, I will conclude. I want to first acknowledge and thank the amazing teams, not only the data collection teams in both of these spaces, but also the team at IRIS, USAID, and Tetra Tech, also our expert reviewers, and a huge thanks to the teams at Emory and at Athena. So please feel free. I won't name you all, but please feel free to turn on your videos at some point and simply wave. It's been a huge effort from everyone on both sides. So thank you very much, and we'll take the last 10 minutes. Hopefully there's enough time for questions. And I think I saw maybe one pop up in the chat.
Great, thank you.
So I see one question by Portia, and let me actually, in terms of the rate of refusal. So we did, let me see if I have that. So among those who refused or were ineligible before the screening process, around 40% of those, so among that group, refused overall. And what's interesting is the proportions, I think, were comparable across those locations, with I think a slightly higher number in Kenya. But that's all, that will be all specific in the report, those specific numbers. You can see that, yeah, Portia, this is the slide that we have. We have the total refused and inaccessible pre-screening. So we kind of clumped right here all that were sort of ineligible pre-screening into this one proportion, but we have it disaggregated by those who were no one home, were household inaccessible, and actually those who were home but outright refused in the report. And those numbers were fairly comparable, but I think with a higher proportion in Nepal. We can look at that, and maybe one of our team members can also look at that. It's the updated table 3, if there is if there are just differences. Let's see. I'm just reading through, but feel free to turn on your mics and ask questions as well.
And Bethany, I'm sorry, but my power just went out. So I just switched from my computer to my phone.
Oh my gosh.
Yeah, it's one of those days. So please feel free to just keep sharing, because I don't have quite as good a functionality as I should.
Okay, great. Well, I'm glad that the whole thing kept running. So Brian, can you speak to how you think the core questions would transfer to a phone-based survey? I actually think that they're fairly, the majority of the indicators, with the exception of the WASH and workplace environment questions, are simply responses to a single question. And so I think those ones could potentially translate easiest. That being said, we didn't test this, so I can't say for sure. The ones that ask about the workplace have a variety of skip patterns related to them, in terms, and also, first of all, do you have a place at your workplace to go? So, and then there's also multiple questions to answer some of those questions. If you remember, like, is it safe? Is it lockable? Is it available? So that would those ones would require more time and would, and also more analysis to actually get at the proportions. And you would need to take in digital literacy of each participant to do that via phone. Yeah, especially if it's via SMS versus the voice, as Brian noted.
I think there was another question from Brian a little earlier on, Bethany. I've just posted it up.
Aside from the emphasis on work-related considerations, can you share any notable differences in the core questions proposed here versus the current JMP core questions? Yeah, so I don't know how familiar you are with the, how familiar all of you are with at least the workplace, at least with the school WASH JMP questions. One of the questions in there is they ask about whether something is usable. But usable has a note that also means that it's private and functional. And so what we tried to do, one of the main differences, what we tried to do is specifically disaggregate that specifically in asking for those specific questions. Usable is kind of hard to, as an indicator. So instead of instead of just calling it usable with a note of what usable means, we try to break it down and be more specific about what we meant there. So it's different in terms of how it's communicated. The other thing in the sort of more advanced one is this element of like lockable. I think JMP does collect some information on that. The other thing that's important is that, and this is something that I think that we also, in the work that we're doing with girls related to monitoring MHM, menstrual health and hygiene with girls, are these school level indicators. So you could have a school of 500 people and you could have a school of 12 people. And really what it's only getting at is there a facility that is all of those things? So each of those schools could come out and say, yes, we have a facility that is, clean, safe, private, usable. But if you have one facility for 500 versus one facility for 100, it's still going to be recorded in the same way. So one of the major differences really is that we're asking at an individual level versus asking at the workplace level. And I think that actually brings a lot of strength, because we're asking individuals where they're changing and what the characteristics are of that specific place. Of course, we're missing data on the workplace level, but it's actually gets us a better sense if those who are working have their needs met during menstruation and what that proportion is. Does that help? And is that what you were looking for? Yeah. Okay. Thank you.
So we have a couple minutes left. If anyone has any final questions or observations, or Bethany, if you and the team have any major recommendations that USAID should be thinking about, feel free to share those as well.
Sure. There's one question here from Zach in the chat, and Lisa, you might actually be the best suited for that question. I don't know if you can see it on your phone, I can read it to you.
That would be very helpful. Thank you.
Great. So could you touch on next steps a little more? I'm interested to know how the indicators and the survey will be shared, promoted, and disseminated, and if there are plans for further development of indicators in coordination with the JMP.
That is a great question, although I am going to kick some of that back over to you, Bethany, given that you're also working with JMP. But yeah, Zach, we're very keen to take this shorter set of survey questions that the team has developed here and really think about what they mean in terms of custom indicators for USAID activities, but also to look at things like our collaborations with DHS, identify gaps, and and also just really make sure that this is thoroughly disseminated across the agency, because as you will have noticed, there's a lot here about WASH. There's also a lot about sexual and reproductive health, about broader gender and women's empowerment issues. And so we really want to look at how this can be spread across the agency's sort of M&E portfolio, and use it as a tool for raising awareness of what's possible with our missions, as well as in their conversations with national governments. And the ultimate vision would be to move towards comparable data sets that it's really easy for national statistical agencies to use, so that we can better target the whole host of MHH interventions. But I would invite Bethany, if you want to add anything specifically about JMP, recognizing that only some of these indicators would be within the SDG 6 remit.
Right. So that's a really important point, is that yes, only some of them would be in that remit. The other thing is that I think in terms of what the JMP is currently monitoring at schools and at the household level related to menstruation, so individual level, what they most recently reported, is as well as the work that was by that global monitoring group for the girls indicators. Both of those started with some shortlists, but then became vetted by a wider group of people that included broader stakeholders. So this is a really important, I think, starting point, but one of the things that, it needs review by people at JMP, first of all, and also other global stakeholders, in country as well, to see not only those related to JMP, but those unrelated to JMP are priorities for taking up. The other thing is that, yes, I will be working with JMP. We have created a review of gender-related indicators for SDG 6, but even within that review, there needs to be, and one of the things that we realized is that there's a need to have that great list vetted and prioritized, because we can't measure everything. So this is already a list, this 12 plus, 12 indicators, but it's more questions. That's way more than we can add to a DHS. So there needs to be an identification of, like, yes, this might be a short list of things to ideally follow and monitor over time, but which among these is actually something that should be taken up and regularly monitored. So that involves a lot of questions overall, and hopefully there'll be more work to sort of use this as a launch point. I see Anu had her hand up. Did you want to share?
Thanks, Bethany. Just to add, to respond to also Zach, during our research process, we also interacted with key stakeholders and actually champions of MHH in both Nepal and Kenya. And we had discussions around what they would like to monitor and measure, because both of these countries have policy priorities around MHH, though they are mostly looking at schools and household settings. But at least in Kenya, there was an interest and a recognized gap of need to focus on workplace. So I think it's also important to go back to those set of stakeholders and present what we have, come up with. They were also talking about, results-based monitoring. So yeah, I think that is also a useful next steps. And I know that IRIS Group also has their own technical groups. So perhaps this could also be disseminated with that core team, and maybe Aditi could speak to that.
Thank you. I know we are at time, and I imagine that all of us have a call to move on to. So I'm going to bring us to a close with massive thanks to Bethany and Anu and the team. It's just really fascinating work. And just a reminder, I put it in the chat, but on January 19th at 8:30 a.m. Eastern time, we'll be doing a full results dissemination event for the entire activity. So we'll have the chance to look at this, this great information in a larger context associated with the action research that was also conducted. So thank you. Huge congratulations to the team. This was an enormous amount of work, especially on a tight timeline and in the context of COVID. And we're thrilled to have such a comprehensive data set from these two countries.
Thank you all. And thank you to the Emory and Athena teams once again.
Thanks, everyone. Have a great day.
Thank you.
Bye.
Right.